Hypospadias is the development of the urethral opening on the ventral side. It can be of five major types: the glandular type, the subcoronar type, the penile, penoscrotal, and the perineal types. Hypospadias is one of the most common congenital anomalies with an incidence of 1 in 250 newborns. The term hypospadias, hypo means under, spadon means rent or opening. Galen coined the term hypospadiosis. John Deckard coined the term hypospadiology. Clinical definition: abnormal ventral opening of the urethral meatus anywhere from the glans penis to the perineum. It arises from an arrest in the normal development of the urethra, foreskin, and ventral aspects of the penis. Clinical presentation: downward directed urine stream, difficult during intercourse, male infertility, hooded perfuse, and cordy. The normal penile anatomical layers are the skin, superficial dartos fascia, areolar tissue, deep buccal fascia, tunica albuginea, corpora cavernosum, which is paired and contains the deep artery, and ventrally the urethral spongiosum. The structures which are affected in hypospadias are the urethral spongiosum and glands mainly. The structures which remain normal are the neuronal innervation, corpora cavernosa, tunica albuginea, and the blood supply. The hypoplastic spongiosum is evaluated intraoperatively and it appears as a transparent glistening membrane after degloving and is used to make a proper cover to prevent fistula formation. Pathogenesis cascade. Chromosomal programming. SRY gene determines Y chromosome. External genitalia are initially indifferent. In step 2, early development, fourth of week, testosterone and dihydrotestosterone formulate the genital tubercle. Step 3, androgenic stimulation, which happens at the 9th and 12th week, masculization induced by the dihydrotestosterone. The fourth step is the formation of the urethra, urethral plate, urethral groove, urethral fold, fuse proximal to distal. Kurzrock theory: granular urethra forms via endodermal transformation. In the hypospadiasis, at the 12th week of androgenic stimulation, the production of testosterone, conversion to dihydrotestosterone, or the receptor activation, there can be disturbance occurring at any point which results in the pathogenesis. Causative factors of hypospadias are increasing globally due to environmental pollutants and endocrine disruptors. Genetic factors: 10 to 20% sibling risk. SHH, HOX gene expression defects lead to the condition. It may be sporadic or syndromic, unknown causes. Endocrine disruption, estrogen treatment in pregnancy, 5-alpha reductase deficiency, and association with androgen insensitivity syndrome is noted. Environmental toxins, OCPs, pesticides, detergents, and commercial plastics are also known to be responsible for the condition. Drugs and maternal factors like diethylstilbestrol, nystatin, corticosteroids, iron, loperamide, high risk of maternal age more than for 35 years, and low incidence is noted in maternal age less than 20 years. Placental insufficiency causes reduced androgen availability. The severity gradient. Anterior account to 70% of the cases, in which glandular is the most common and the mildest type, coronal, and the distal penile. The midshaft defects, the posterior or proximal cause severe cordy and are noted at the proximal penile, penoscrotal, scrotal, and the perineal is the most severe type. Culp's method of severity assessment is not just based on meatal location. It includes the cordy correction, the position of meatus and extent of cordy, and the third step, the hypoplastic corpus spongiosum, the most important parameter for severity grading. Cordy vector. It is the downward bending of the penis on erection due to improper development of the ventral aspect. In distal cases, it occurs in 10% times and proximal cases 50% times. The more proximal the meatus, the more severe the chordae. Pathological mechanics. Most common cause is the hypoplastic ventral skin, deficiency of ventral dartos fascia, hypoplastic urethra, deficiency of tunica albuginea, disproportionate growth of corpora cavernosa are responsible. Chordae without hypospadiasis occurs due to deficiency of the corpora spongiosa, thin urethra, and abnormal buccs or dartos fascia while the skin remains intact. Associated abnormalities. Local genital abnormalities are the hooded purpose, urethral plate abnormalities, gland size abnormalities, penile torsion, which can be left or the right tilt, pinoscrotal web, or transposition. Systemic association. 32% cases undescended testis is noted in the proximal cases. Inguinal hernia is also seen. It also has association with psychosexual problems. There is social outcast and severe ambiguity. Disorders of sexual differentiation should be definitely ruled out by carrying out mandatory karyotyping, as most of them have undescended testis. 50% have impalpable gonads and 15% have palpable gonads. As the male child develops genital awareness by 8 months of age, the surgery should be planned and done between 6 to 12 months of age to have a normal psychosexual development. The golden rule: circumcision is strictly contraindicated as the foreskin must be preserved for surgical reconstruction. Preoperative hormone stimulation protocol. Indications for it are presence of small phallus, failed hypospadiasis, that is hypospadiasis cripple, small or hypoplastic glands. Pharmacological agents used for this are the testosterone cream or injection 2 to 3 mg per kg per dose, HCG injections 100 international units per kg bi-weekly for 5 weeks, dihydrotestosterone gel of 2.5%. The surgical reconstruction occurs mainly in 5 steps. The orthoplasty, where chordae correction for a straight penis is the primary goal. The urethroplasty, urethral repair and reconstruction is done. Meatoplasty, creation of a natural slit-like meatus is taken up. Glandsplasty, reconstruction of the conical glands over the neourethra is done. Perpukoplasty is the ensuring adequate skin cover of the penis. The general surgical principles followed are 2.5 to 3.5 times optical magnification and fine instruments are used. Hemostasis via tourniquet is acquired by and it is opened every 20 to 30 minutes. Diluted adrenaline is used for irrigation in ratio of 1 in 1 lakh. Postoperatively, bladder drainage, caudal block analgesia, and oxybutynin 0.1 to 0.2 mg per kg TDS is administered for bladder spasms. Orthoplasty is mainly carried out by 5 main techniques. The Smith's principle, which involves the degloving of penile skin, Nesbitt dorsal plication, in which elliptical incision is given over the tunica albuginea at 2 o'clock and 10 o'clock position, Baskin and Duckett's, in which tunica albuginea approximation is done in midline, Baskin's dorsal plication, where corporotomies are done for fairy cut lesions, Poppies, in which dermal graft technique is taken up, Serowick's penile disassembly technique is done. The verification protocol. It was developed by Gittis and Macklon in 1974. After the orthoplasty, the adequacy of it is tested by corporal saline injections. A tourniquet is applied at the base of the penis. 3 to 5 ml of NS is injected into the corpora using a fine 23 to 26 gauge needle. It assesses visually and palpably for any residual downward deformity. The surgical procedure can be carried out in single stage or the two stage as required by the severity of the condition. Anterior or the distal, in the 70% cases, single stage surgery is carried on. In midline, the single or two stage is opted as per the severity and the chordae deformity. The proximal or the posterior with severe chordae definitely need a two-stage surgery. Two-stage repair is the Bracas repair and is mandatory for severe hypospadiasis with profound chordae or inadequate ventral skin. The critical axiom is the only flaps demonstrate significantly fewer complications than tubularized flaps. The most common complication of the hypospadias repair is the formation of the urethro-cutaneous fistula. The hypoplastic spongiosum leaves a transparent glistening membrane after degloving. Without mechanical protection, urine pressure causes the defect. The urethral coverage using a dedicated well-vascularized flap provides structural and biological barrier for the fistula formation. The established three ways of the barrier layer techniques. The first one is the retic technique in which dorsal dartos fasciae is used, the snow technique in which tunica vaginalis is used, and in the last procedure, scrotal dartos is used. The urethral plate provides the best surgical results and is always preserved unless severe chordae demands its sacrifice. Post-operative complication, urethro-cutaneous fistula, which accounts to 10 to 30% of the cases post-operatively, is the most common and feared complication. The structural failures are noticed in glans dehiscens, meatal stenosis, recurrent or residual chordae, urethral stricture, and urethral diverticula. General risks and chronic state are the hemorrhage, post-operative infection. The clinical state, hypospadiasis cripple, is a devastating state of failed hypospadiasis where no ventral tissue remains for further repair due to multiple unsuccessful prior surgeries. The revision sheet. Tersch and Duplé, father of hypospadiology. Galen coined the term hypospadias. John Duquette performed the hypospadiology and meatal advancement and granuloplasty surgery. Snodgrass did the tubularized incised plate surgery. Gates and Macklon did the corporal saline injection test. The master axioms: the repair needs to be done by the age of 1 year, preferably 6 to 18 months for optical psychosocial adaptation. Circumcision is strictly contraindicated. Assessment and correction of chordae is the primary surgical goal. Degree of hypoplasia of ventral tissue. Spongiosum is better severity metric than meatal position alone. Urethral plate needs to be preserved and sacrificed only in cases of severe chordae. The most common complication is the urethro-cutaneous fistula. Disorders of sexual differentiation must be ruled out via karyotyping in severe cases with an undescended testis. Thank you for joining for the session.